Okay.
Already?
Go ahead.
Okay. I'm just getting to my agenda, getting to the agenda here.
I can share it on the screen, Chris, if you'd like.
That's okay, I found it.
Okay.
Okay. All right. We'll call this meeting to order. Meeting of the Dunn County Criminal Justice Collaborating Council Family Treatment Court Oversight and Planning Work Group. But if we shortened all of that into letters, that would be a bunch of letters. Let's see here. For the sake of us being live and on Zoom and it being an official meeting, let's do a quick round of introductions or acknowledgements, at least, of who's in the room and what you're representing. I'm Chris Corpola. I'm the director of the Dunn County Department of Human Services and the chair of this committee. Sarah?
I'm Sarah Benedict, Dunn County Criminal Justice Coordinator, and welcome. Thank you, everybody, for joining us. This is kind of a combined group. We've got our Family Treatment Court Oversight folks here. We also have our Adult Treatment Court Advisory here as well, and their teams. So thank you all for joining us. So we've got a lot of new faces. So thank you for the introductions as well, Chris. So I'm going to pass it on to Lindsay.
Lindsay Field, Integrated Treatment Specialist with Dunn County Treatment Court, Family Treatment Court, so part of the CJCC.
And if each of you would follow Sarah's lead and just pass it on to the next natural person, that'd be great.
I'll pass it on to Janae.
Hi there, Janae Brantner, Dunn County Adult Treatment Court Coordinator and Treatment Opportunity Program Coordinator. Derek?
Derek Smith, Dunn County Family Treatment Court Coordinator. Melissa Berg.
I'm Melissa Berg. I am a social worker in the Family and Children's Unit assigned to the Family Treatment Court team.
I am Kayla Johnson, ongoing child protection worker with Dunn County Human Services, working with Family Treatment Court. Lori.
I'm Lori Radcliffe. I am one of the managers in the Family and Children's Unit and kind of oversee Kayla and Melissa, who are part of the Family Treatment Court team. Carrie.
I'm Carrie Anderson, the other Family and Children's Services Manager at Dunn County Human Services. Chris Meyer.
I'm Chris Meyer. I'm a local attorney and I'm on the Family Treatment Court Board. And I don't know who's next.
Pick somebody.
I'll take it. I'm Jenny Bassett. I'm a physician in internal medicine and pediatrics, and I'm the medical director for the Northwest Wisconsin Comprehensive Treatment Center, which is a methadone clinic. And I do a lot of substance abuse treatment. And thanks for having me today.
Brianna.
I'm Brianna Trout. I do peer support for Milkweed Connections. And I want to apologize. I have my son with me. So if you hear
Don't have to apologize. Yep, don't have to apologize. It's called life these days.
Yeah.
Chris King.
Chris King, Menominee Police Department.
Amber.
Hi, I'm Amber Hahn. I'm on the Adult Treatment Court and I work in the Dunn County District Attorney's Office.
Paul?
Paul Gilbertson, Probation and Parole.
Andrea.
I'm Andrea Nodoff, the Dunn County District Attorney.
Judge Smeltzer.
Rod Smeltzer, Branch 2 Dunn County Court Judge. I'm on the Family Treatment Court Judge.
And Caitlin.
Hi, I'm Caitlin Engel. I'm the public health educator for the Dunn County Health Department.
All right. I think I got everybody.
I missed Tani and Sandy.
And Nikki.
Tani. Oh, geez,
Hi, I'm Tani Strong, and I'm a clinical substance abuse counselor at Arbor Place, and I'm on the Family Treatment Court team.
Andy?
Sandy Frigo, Criminal Justice Assessor.
And Nikki.
Nikki Walsh. I am a recovery coach and peer mentor with Milkweed Connections.
All right. Thank you all for being here. So for the Family Treatment Court Oversight piece, I'm looking at minutes from our September 2 of 2020 meeting. I'm looking for someone to make a motion to approve those minutes.
So moved.
Motion by Judge Smeltzer, second by Chris Meyer. Any discussion? Otherwise, all those in favor of approving those minutes signify by saying aye.
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 Motion carried. All right, for the sake of making the best use of Dr. Bassett's time, would you like to move her, Sarah, up to this time frame and let her speak? Or maybe you would like to do an introduction and tell us what we're going to be listening to.
Well, I would like to express our gratitude to Dr. Bassett for joining us today. She is an expert in the field of addiction, so that's certainly our business and the folks that we work with. So just appreciate her bringing her expertise and joining us today so we can learn more about medication-assisted treatment, MAT. We're starting to see that more and more with the participants that we work with. So wanted to use this as an education opportunity to hear right from the doctor as far as MAT. So I'll just turn over the floor to Dr. Bassett.
Thank you. I'll be brief. What I'm going to do is talk about just briefly about the purpose of MAT, the upside, the downside, the complications, and then I'll take any questions because people always have questions about specific cases and problems that they've seen in the past. So medication-assisted treatment is generally used for opiate addiction. We often see people in the methadone clinic that have other addictions, but they have to have a history of opiate addiction to qualify for the program. So the purpose of medication-assisted treatment is basically to eliminate the withdrawal symptoms and illness that people struggle with when they stop using opiates, and also to control drug cravings. It is currently the most effective treatment there is for opiate addiction, and that's why you're hearing more and more about it, because there is so much opiate addiction, and this is the most effective thing we have. The upside is that at an appropriate dose in an appropriate setting, the medication will eliminate a person's cravings and eliminate the withdrawal symptoms that drive them to using again, and they can basically function as normal people. The downside is that, in my experience, this is my opinion. My opinion is that people with addiction often have it in their head that they really just cannot survive without a substance. And I do think that medication-assisted treatment sort of perpetuates that in some people, but it also makes them far more successful in taking care of their own kids, staying out of jail, keeping a job, paying their own bills, staying out of the social service system. So in the grand scheme of things, I think the benefits greatly outweigh the downside. It's basically a form of harm reduction. So if you look at people on medication-assisted treatment versus people that are on an abstinence-based program, they are much more likely to be successful in all of those realms that I just discussed. The issue of dosing came up. The appropriate dose for someone on medication, could you shut the door? Yeah. Medication-assisted treatment varies hugely from person to person, but it has nothing to do with a lab test. The appropriate dose is the one that makes the person feel like a normal person. If they are sedated or nodding out, then their dose is too high. If they are still struggling with cravings and withdrawal symptoms, then their dose is probably too low. It's amazingly rare to see somebody whose dose, who is still having withdrawal symptoms and drug cravings, and also experiencing over medication. So usually there is a magic number in there for each individual person. Now, it can be a little bit tricky because people with addiction will often think they need more than they do, and they don't have a good sense of when to stop. And that's why medication-assisted treatment is best provided by somebody who can watch for those things and help guide them into what is truly an appropriate dose and not just more is better. Questions?
Dr. Bassett, could you just speak to the methadone clinic and how that, what that's structured, what that looks like? What does a participant experience when they either, how do they get to you? And then what do they experience once they get there?
Sure. So if a person has a history of opiate addiction, they call the intake line, they get an appointment, they come in for a very long intake during which they see a counselor that gets a complete biopsychosocial history. They see a nurse that gets their medical history. They see me. I pick a dose that I think is appropriate for them based on their level of use. So if they use 2 Vicodin a day, it's going to be a low dose. And if they use a gram of heroin a day, it's going to be a higher dose. There is a limit as to how much we can use for a starting dose, which is picked by the state. And then every day we increase their dose by a little bit until they feel normal for 10 to 12 hours. And then we increase it every 3 to 5 days as they get closer to feeling normal for 24 hours at a time. So the goal is for them to feel normal for 24 hours at a time. But we slow down the pace of getting to that dose basically for safety reasons. Also, sometimes it takes a few days for a patient to know if the dose that they're on is going to be effective. The patients have pretty rigid requirements for counseling, which is initially once a week. We do drug screens initially once a week or more if we think it's appropriate. After 90 days, if a patient has basically met all the requirements, passed all their drug screens, met all their counseling requirements, been at the clinic every day for dosing, they can earn 1 day a week of a home dose. And once they earn 1 home dose, every 90 days they can request another one. And again, it requires basically perfect attendance, etc. When people have home doses, we randomly call them and have them bring their bottles in and we check them and make sure that the bottles that are empty, that are supposed to be empty, are empty, and the bottles that are supposed to be full are full. The problems that we have are that we only see people for a short period of time in the morning. And so if they are not on an appropriate dose, sometimes we can't see it because they look fine when they come in the morning, but they might not look fine later in the day. So we always appreciate input from others. And of course, if a family member or if a law enforcement or a social worker calls us with a concern, we can't say anything without a release. We can't acknowledge that the patient is enrolled there, but we can take the information and we always act on that information. So for example, if I got a report that someone was nodding out in a counseling session later in the day, we would have that patient sit for 3 or 4 hours after they dose. That's when methadone peaks in the system, and we would evaluate the person at that 3 or 4 hour mark to see if they're on too much methadone. If they are, we drop their dose. Oftentimes they're taking something else that's making them nod out in the later afternoon. And if that's the case, we keep them on what we think is an appropriate methadone dose, but we would address the additional use in counseling. Other questions?
Could you also just speak to the difference between, also speak to the difference between the use of methadone versus the use of like Suboxone or Vivitrol?
Sure. So methadone is older. It is one of the most highly regulated medications produced. And so the rules and regulations about administering it are very rigid. Any doctor can prescribe methadone for pain, but it has some tricky pharmacokinetics. It has a very long half-life, which makes it difficult to adjust for acute pain. It's very good for chronic pain, and some cancer doctors use it. So any physician with a DEA number can prescribe methadone for pain, but most do not. But only a physician in a registered clinic like a methadone clinic can prescribe methadone for addiction. Suboxone can be prescribed by any physician who takes a 9-hour certification course, which is available online. It is safer than methadone in the sense that it tends to block the effect of opiates. So if somebody is on Suboxone and they take an opiate, they will not get as much of a high from that opiate as they will without it. Methadone has somewhat of a blocking effect, not quite as much as the Suboxone, so Suboxone is considered safer. The downside of Suboxone is that, in my opinion, it's not a great medication to be used without a counseling program. So I have a handful of patients that I treat from the internal medicine clinic that are on Suboxone, but mostly I refer them to the methadone clinic because the program is much more comprehensive there. And all I can do from my internal medicine clinic is write them a prescription. I don't have a counseling system here. And of course, addiction is complicated. The upside of it is it's easy and it's, it just makes a medication-assisted treatment more readily available to a broader number of people. Vivitrol has no addictive potential at all. It is basically an inert substance, and it merely blocks the effect of opiates so that if you use opiates, you don't feel the effect. It also has some benefit in terms of control of cravings. It's not as effective as Suboxone or methadone, but it is nice to have as an option. It's a monthly shot, and we use all of those at the methadone clinic. We use Vivitrol, Suboxone, and methadone.
How long does MAT typically last, or how long can it last? Is it something that could be a lifelong thing?
Well, we officially tell people to plan on 2 years. Most people that come to us have been addicted, have been abusing opiates for 10 years or more. So we tell them to plan on 2 years. The truth is that some of them come and want to get on it and off it very quickly because they have a deadline. Maybe they're using heroin and they know they're going to jail, or they're trying to get their kids back and they need to have clean urine drug screens by a certain point. If they have a specific timeline, we'll work with them. As far as the end point, the truth is that some people who are opiate abusers know that no matter how long they're on MAT or no matter how long they're in counseling, when that medication is gone, they're going to relapse, and they lose everything when they relapse. And so those people might decide to stay on it, sort of like taking a diabetes medication or a high blood pressure medication, because they have so much to lose if they taper off it and slip up. And, we have people that are business owners or professionals that are just tired of going through that cycle. And so they just stay on it because every time they've been off it, they've relapsed.
Can you speak to the mixture of alcohol and MAT?
Yes. We don't allow alcohol use. Obviously, we don't test for it as much as we test for other things, but we breathalyze people that we know have an alcohol history, and we don't allow people to use alcohol in the program. So, for example, if you are using alcohol and you blow positive in the morning before your dose, we will not give a dose because it's risky. If somebody is abusing alcohol but blow negative when they come in, we will give them a dose, but they will not be eligible for take-home doses. So they have to be absolutely abstinent for us to consider them safe in the community to manage methadone on their own.
Can you speak quickly to the dangers of mixing the two?
Well, it's because both of them are sedatives, and the combination can produce enough sedation to cause respiratory suppression. The truth is that we don't often see, when we see deaths from methadone, this might be because people tend to drink in the evening and they tend to take methadone in the morning, but much more dangerous combination is the benzodiazepines and methadone or Suboxone. And so we work really hard with patients who use benzodiazepines, whether it's legally or illegally. Different programs have different policies with respect to THC. We don't allow it. It's like alcohol. Even if it becomes legal, we will still not it's not that we don't allow it. People can use it. We have lots of patients that, are never swear to us they're never going to stop it, but they will also then never be eligible to take methadone out of the clinic or Suboxone. What else you got? Cases, questions?
Can you speak to funding in terms of the types of payments that people can utilize in order to obtain MAT from the methadone clinic?
At the methadone clinic, patients either pay cash or Badger Care covers MAT, and many private insurance, I think actually maybe all private insurances since Obamacare have to cover it, but it's a little bit of a problem with private insurance because the patient has to pay up front and then apply to their insurance company for reimbursement. Before Obamacare and the mandate that mental health be covered, it was actually hard to get commercial insurance to cover MAT. It's a good deal if you're spending $100 a day on heroin. Even paying cash, I think it's about $19 a day for methadone and $23 maybe for Suboxone, and I'm not sure what it is for Vivitrol, but it's much cheaper. But as you get, as you progress, if you're not using heroin anymore, then $19 a day becomes a lot of money. So people will sometimes leave the program for financial reasons. Does that answer your question?
Absolutely.
Suboxone, of course, is covered basically Suboxone is the same in the methadone clinic, except it's more expensive. In the private clinic, Suboxone is covered by most insurance plans, just as a regular prescription.
Doctor, I just got a quick question here. When you talk about the MAT treatment, how does that deal or coincide with the ancillary behaviors that go along with addiction? What role does that have to play? Go ahead.
Well, as you all know, those are very, very much intertwined. And we know that people do better with treatment of addiction if their mental health issues are addressed. And we know that people's mental health issues are better addressed if their addiction is treated. So we have a mental health provider in the clinic. Not all clinics have a mental health provider, but by law, they have to have access. They have to have a referral system for mental health issues. So we use the mental health provider that we have, and we also refer to counseling clinics around town and other psychiatry or other mental health providers. And as you can imagine, it comes up every day. Sometimes we see people that just aren't making any progress, and we will tell them that if they want to continue their treatment in the clinic, they have to seek mental health. They have to seek treatment for their mental health issues, because otherwise we feel like the program just isn't going to work for them.
So piggybacking on Judge Smeltzer's question, if someone is being, I'm going to say properly, not versus improperly, but dosed to the effective dosage, what would their behavior look like compared to someone? I mean, okay, I realize that's a really loaded question because I don't know what you could tell me what my behavior would look like. But I mean, as in general, should someone who's being dosed appropriately and kind of working their program, should they be able to function kind of in a regular capacity, given whatever else might be going on in their life, parent children, or effectively hold employment, or those types of things?
Someone who is on an appropriate dose of medication should be indistinguishable from a non-addict. So if you're seeing sedation, if you're seeing abnormal behavior, then they're either using something else or their dose is not proper. They should be indistinguishable from a normal person.
And doctor, I think you've already alluded to this, but you welcome, I guess, or would receive information that we might have if we are kind of seeing some of those perhaps overdosages or underdosages. Is that something that you're open to us communicating with joint clients?
Not only am I open to it, but I think it allows us to give much better treatment. The clinic is only open from 5:30 in the morning until, patient hours are until 11, and I think the clinic closes at 2:30. So it's kind of an early morning deal. And we don't see patients later in the day, but you all do. So I think you can help us give better treatment. You know, like I said, people with addiction, some of them are great judges of what dose they need. And they, you know, they get to 50 milligrams and they feel like a normal person and they stop right there. Some people don't have that shut off mechanism, and everything in them tells them that more is better. And I think they honestly don't, you know, some of them may be deliberately trying to get more to get a high, but most of them I think just don't have any sense of what normal should look like. And so they need outside observers to help them. And yeah, so we absolutely welcome the input. It's not very satisfying to call us, I think, because we can't even acknowledge if we have the patient there. So most of the calls I get are from people who know me and know that that the patient is there. And so, like I said, it's not very satisfying to give us information and get nothing in return, but we do greatly value it, and we do act on it always.
Can you speak about what avenue is best for pregnant women?
If a pregnant woman is actively using, medication-assisted treatment is known to be safer than no treatment. It's known to be safer than active use. If a person is actively using and is going to jail, then I would say abstinence is the best route because you can enforce no use. But if the person is out there on their own, medication-assisted treatment is safer than street drug use. The dangers of stopping so it's never appropriate to get somebody started on methadone or Suboxone when they're pregnant and then stop it while they're pregnant because it can cause miscarriage and stillbirth. And I have seen that happen when a provider who doesn't know that thinks that it's, you know, they're better off on nothing. So first off, they don't end up on nothing. They end up back on heroin. But secondly, there are some risks to stopping it abruptly during pregnancy. We don't know of any long-term effects of methadone and Suboxone on childhood outcomes, but there may be long-term effects, but it's been hard to tease those out from active drug use. So oftentimes patients that are on methadone or Suboxone are not absolutely abstinent from other drugs or used them early in pregnancy and then got on methadone and Suboxone a little bit later. So it's a little bit harder to tease out those issues. I suspect there probably are effects, but they're less dramatic and damaging than active street drug use. When babies are born, they have about a 50-50 chance of going through opiate withdrawal. And in the hands of someone who knows how to manage that, it's not a big deal. It's easy to manage.
The 3 medications that you identified, knowing that a pregnant female can go up on their dose of methadone and Suboxone while they're pregnant, how does that work with Vivitrol in pregnancy?
Oh, that's a very good question. So let me take the first part of that first. So women's need for the biggest risk to the woman, the biggest risk to the baby is for the woman to be on an inadequate dose and for her to be in withdrawal. That's what can cause the miscarriage and stillbirth. So very frequently, the dose will go up during pregnancy as mom's metabolic demands go up. So we tell pregnant women that if they're starting to, first of all, it's very likely that they will need a dose increase. I can't remember if I've ever seen somebody not need a dose increase. And it's very, very common to need a dose increase right before delivery. And I think sometimes, I know that I've had conversations with nurses who don't understand that that's a physiologic phenomenon. Has really nothing to do with the patient's addiction. It has more to do with the pregnancy and the physiology of pregnancy. So we want to absolutely keep the mother out of withdrawal. And so it's almost inevitable that her needs will go up as the pregnancy progresses. Vivitrol, I'm going to be honest, I've not used Vivitrol in pregnancy. All the Vivitrol patients that I've had so far, I think have actually been males. I don't think there is a dose adjustment for pregnancy for Vivitrol that I'm aware of.
Are there any other questions? Oh, go ahead. Sorry.
So you all know how to get hold of me. I'm very open to, talking to people that have questions, or if you have a question about a specific case, or what you think is appropriate. I'm not a BSer, and so if I think it's not appropriate, I'll tell you. And so, just feel free to always email me, or if you call the clinic, they'll give you and they know you're a professional, they'll give you my cell phone number, and I'm happy to talk or answer questions at any time. We're all in this together.
Well, we super appreciate you coming and speaking with us today. You get a broad cross-section of both of our treatment court programs, and it was relevant information to everyone. So thank you very, very much for taking time out of your day to help us out.
Thank you for having me. Have a good afternoon.
Thank you.
Thanks. All right. In the interest of time and making sure that we get to kind of the things that we need to, I would also suggest we alter our agenda a little bit to talk about a potential, as you're all sitting here from the two courts, a potential proposal to combine Family Treatment Court Oversight and the Planning Work Group and the Treatment Court Advisory Group. So, Sarah, do you want to speak to that? You want me to speak to that?
Sure, I'd be glad to. Just to give a little context, as I mentioned, we've got two groups that are joining today. We've got our Family Treatment Court Oversight and Planning Group, but we also have our Treatment Court Advisory Group. And essentially, both groups kind of serve the same similar purposes as far as providing some guidance, some oversight to the treatment court programs. Chris Corpola leads up both of those advisory groups. This one tends to meet quarterly. The adult group had just made a motion to meet twice a year. Us bringing in Dr. Bassett is a great example of how there's a lot of overlap in the activities, the discussion that would benefit both groups, and essentially kind of reduce the number of meetings that we have each year. So it is a recommendation that we're hoping to have a discussion. If there's strong feelings either way, we can certainly leave things as they are. But if this group was interested in kind of joining forces, and we would have to come up with a new name, probably Treatment Courts Advisory, but it would certainly eliminate duplication of efforts and meetings and topics. Plus, with the two different programs, we're really wanting them to be follow the model and be kind of similar in service structure. So so I'm just gonna, I guess anything that you want to add to that, Chris, feel free, but that's just kind of my perspective of where we're coming from.
I think the only thing that I would say about that is we've had a hard time being that adult treatment court is an older program than family treatment court. I think we've had a hard time finding relevance to the adult treatment court advisory group to make it make it worth people's time to be there. And so today was, as Sarah mentioned, an example of what we're considering for a number of different meetings that we do, is really to use this meeting time to do brief exposures to other information that's relevant to what we do. In this particular case, certainly super relevant to the treatment court programs. So I'm certainly an advocate of combining the two, because I don't foresee that there's something that's lost in that from a large picture of oversight and planning purpose. But like I say, as Sarah said, there's not any reason that we have to, and we can certainly continue with the model as we have it. By way of kind of parliamentary procedure, what would happen was someone would make a motion to combine those two groups. We need a second, then we could have discussion, and then ultimately a vote. So the motion does not necessarily mean that the end result is the combination. It just opens the door for us to be able to have the discussion.
Just a point of order, Chris. I understand this advisory group, is this a derivative from the CJCC executive board where this would be a recommendation to that board that they be combined and the executive committee would approve it?
Oh, I'll ask Sarah to speak to it from a bylaw standpoint.
Well, I think we've already talked about that, and I think there wasn't much, I guess, perspective at the executive level. I think it was wanting to really talk to the people in the group here to see if they wanted to move forward with that recommendation, and then we take it to the CJCC. So it is on the agenda for tomorrow's CJCC meeting, because
Okay.
both of these groups are out of the CJCC.
Well, my experience, having spent quite a bit of time doing this, I would recommend that you combine the two steering committees or planning committees or whatever into one group. It seems to make a lot of sense because a lot of the same folks are participating in both anyway.
Are you making a motion to that effect?
That is a motion.
All
I
right.
added
Can
a
I
little
second?
verbiage to that motion.
All right. Can I have a second?
I'll second.
All right, Janae's got a second. All right, now I open the door to any discussion regarding pros or cons or strong feelings that people have about that combination. Don't everyone speak at once.
Call the question.
All right, so all those in favor of combining the two family treatment court and treatment court advisory kind of oversight committees signify by saying aye.
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 And opposed? All right, motion carries. We are now officially married. You may kiss the bride or groom or whoever. All right, let's pop back up to the top of the agenda. Staff report. Derek, I believe that's you.
Yes, all right. I will try to make this quick program update. Beginning in 2021, we moved our staffings and court sessions from Monday afternoons to Tuesday mornings. Yesterday was our first court session of the new year. Moving to Tuesdays will allow for a one-day buffer between the weekend and the court session, which is helpful in getting the most up-to-date information for staffing notes. That can happen over a weekend. Whether it be visits, testing, and just the nature of slips on the weekend. So currently we have 6 participants, 5 are female and 1 male, breaking it down into 83% and 17%. Average age of participants is 34. As many of you know, the program has 5 phases. We currently have 1 in phase 1, 2 in phase 3, 2 in phase 4, and 1 in phase 5. Methamphetamine remains the primary drug of use among our participants, with 100% of them having some record of methamphetamine use when referred. Marijuana is the second most used drug among participants, and alcohol is third. Any questions on the program update? Okay. 2020 year in review. Things were tough at first dealing with the pandemic, but we adjusted as best we could and were able to maintain most services. A main component of treatment courts is the drug testing, and fortunately our drug testing partners worked very hard to make the necessary changes to continue operating while ensuring their health and the health of our participants. We were fortunate enough to benefit from a partnership between DHS and Milkweed, which provides parent-peer supports and has proven to be an invaluable asset for our participants. Peer support and recovery coaches are strongly recommended by the Family Treatment Court best practice standards. Breakdown of 2020 numbers. We had a total of 6 referrals for the year, 2 of which started the program. We had 2 unsuccessfully discharged from Family Treatment Court. We also had 2 completions, so we did have our first graduates in 2020. Throughout the year, we served a total of 11 people throughout the year, 9 of which were carryovers from 2019. And we did have one general or neutral discharge. Unfortunately, we did lose a participant to a car accident. Any questions on the 2020 year? Okay. Lastly, we've got annual training expectations and reminders. I took a couple lines from the best practice standards. Wisconsin Treatment Court Standards states that programs that ignore best practices and fail to attend training conferences are more likely to produce ineffective or harmful results. And then from Family Treatment Court Best Practice Standards, research has consistently shown that to operate effective drug court programs, partners must receive ongoing training and technical assistance to build and maintain their skill set. Generally, we want to see operational team members participating in around 40 hours of training annually. A reminder for the WATCP, I will be giving a presentation tomorrow via Zoom with the Family Recovery Court Coordinator, Cassandra Bach from Rock County. The presentation begins at 11:30 a.m. It's titled Family Treatment Court, From Planning to Operation, What We've Learned. The link can be found at watcp.org right on the front page. And then lastly, the WATCP conference for 2021 is scheduled for April 28th through the 30th, and that will be held through virtual, I believe is the course right now. So that's the staff update.
Any questions for Derek?
One thing for Chris, if I could, for Sarah, maybe reach out to, as most of you know, there will be at least 2 new judges entering Dunn County in August 1st of 2021. And so it might behoove, if, depending on how it goes, we might want to reach out to those that are successful, at least even reach out to them beforehand, that we could possibly get them into some of that training in April if it works out, that they would be available. And I was going to ask you that question, Sarah, would we have funds to be able to have those folks attend that training?
Yes, we might certainly do. I think between the grants and the funding, because it won't be in person, we will save the hotel fees, the meal fees, and that's really just as much or more than the actual conference itself. So I think we'll be able to stretch our training dollars to cover anybody that wants to attend that training. And to include the potential judges that will take office August 1st. That's a good idea. Thank you.
Yeah, and I highly recommend it for those folks, because it just gives them a lot of the vernacular and discussion points that at least when you're talking about something, they would have a leg up on being able to understand it and also contribute. So probably be a good idea. So just that.
It also raises the question, Judge, that we could, or raises the, I guess, the suggestion that after we get through the April election and we know who's seated in those spots, that we ask those people to also do some shadowing or some observing of the 2 treatment court processes, because they are a bit of an animal unto themselves.
Yeah, and that's a good idea as well.
All right. Any other questions for Derek? Thank you, Derek. So we have addressed number 5, MAT from Dr. Bassett. Number 6, program fees. Sarah, is that you or Derek?
Yep, that'll be me. The programs have program fees associated with them. It's been recommended by our corporation counsel to put those on hold and not collect program fees right now. There is legalized or looking at it, and at the state level too, it's not clear as far as the order of fees that should be collected. And then we want to make sure that things are properly collected and consistent with the county's processes. So to this point, we have not collected any family treatment court fees. So just making the recommendation that we're following Corp Council's recommendation that we just hold off on that until things become a little bit clearer. So both treatment courts are working through this issue right now. We know it definitely applies to our adult treatment court, not clear how much it applies to our family treatment court. But as you recall, when we were setting up well, some of you may recall as we were setting up our program rules and whatnot, that, we were kind of on the fence about the program fees, because a lot of times these are the folks that have a lot of needs, have a lot of expenses, and don't always have a lot of income coming in. So, so I'm basically not asking for a motion. I'm just letting you all know that we are on hold with those fees right now. And once we get some more clarity, I'll bring that back to the group.
And the issue, Sarah, if I remember correctly, the issue is that there's been a legal challenge to that, right?
Yeah, there is a statute that was put forth in 2015. It was buried, but it really does talk about fees, and things need to be, restitution needs to be paid, court fees need to be paid, fines need to be paid, everything before the county as far as program fees. So we just need to make sure that we, and that kind of came in kind of not with a whole lot of fanfare, that new, that change. So I think even WATCP, which Janae's now part of that, organization's board, they're looking at this too, because this applies not just to us, but all treatment courts in the state.
Any questions or comments about that? All right, moving on to number 7, discussion about systemic changes to increase referrals. This is just a piggyback. I can take this quickly. It doesn't need a lot of attention. This was a conversation that Sarah and I had last week as we were preparing the agenda. We were looking at the numbers of referrals, actually in both courts, but certainly in family treatment court. And I know we've had discussions in this group, in the oversight group, around where referrals can come to, but just a reminder to the all the players in the system that if you see someone that you're working with, whether as a guardian ad litem or as a prosecutor or as a treatment provider or in any capacity that you believe would be a viable candidate for a family treatment court, that those referrals from within our system can come from any direction. So I know that the Family and Children's Services social work staff have been diligent about reviewing on a weekly basis, or at least a few times a month basis, whether there are any referrals in the works. And I know that there's been some folks who've been vetted and either not been interested or had other barriers to participation. But just a reminder to kind of keep your eyes open. And I know that in other programs that are sort of census driven, where you need to have participants in order to keep your program in order, alive, keeping that regularly on the front of everyone's minds helps to make sure that there's a regular referral process, a regular referral flow.
Derek, and this is a question for you to talk about getting people on board for Kayla, Melissa, and Derek with family treatment court. It'd be nice, in my way of thinking, that when you're inviting new people or potential new folks to participate, if we had some type of, I guess, effective promotional material they could watch. Like we've had some people that participate in our court so far, they haven't graduated yet. But I look at Amanda as one example, that her and maybe some others, you could put together some type of video with them saying why this was important, where we started, what the steps were that allowed us to be successful. And if you want your kids, this is a good way to accomplish it.
And Derek, do you want to speak to the work that you guys have been doing around materials?
Sure. It was the bifold flyer was attached with the meeting agenda and the minutes. And that really is just an updated flyer that we can put out in places, but also our core team got together and kind of brainstormed ideas, and I spoke with participants on what it was that they found beneficial of the program, and we did put together, sort of a list that we had, kind of dubbed the sales pitch. So I meet with the social workers and the potential participants typically around the referral time, and those are just some additional things that we've come up with to really highlight what they get out of the program, and why they would participate, because the family treatment court is certainly not the easy alternative, and so we need to give them essentially reasons on what do they get out of it. So it is something that we have been working on. We haven't discussed the idea of a video yet, though, Judge.
Well, yeah, here's the only thing. You make the point that you say family court's not the easiest. It's not the easiest to get through, but it's the easiest way to keep your kids. You got to turn a negative into a positive, otherwise they don't listen.
Yeah, and I would just add that I think it's important to have those referrals as early as possible. We've got a case in our family treatment court now that the timeline's running out, even though she's making progress. So there's a lot of change that people have to make. So the longer that case has been going on, it just makes it more challenging for them to really turn it around. So, to Judge Meltzer's point, if the easiest way to get your kids back is to join this program and get that support that you need to reach your goal and reach our goal as well.
Well, and it's going to be interesting to see. I'm actually just working on the final quarter's report, family treatment court report that we do for the state, and I decided to be serious and actually look at some of the data. And it's just interesting because 2020 is going to skew data all over the place because it's just such an anomaly of a year. What we'll be curious to see is what happens after that, after we're kind of through the greatest part of the pandemic. But it certainly wasn't, I give credit to our groups, both treatment courts, to have been able to stay operational and to work through all of the obstacles of 2020 because, family treatment courts was a baby when COVID hit and still only just a toddler. But we've survived so far, so hopefully there's a little light at the end of the tunnel in the not too distant future. All right, with 5 minutes remaining, and Judge Smeltzer actually kind of did a nice segue into this. We wanted just to talk about the fact that it's going to be another year of significant change in our judicial system, that we have still relatively new prosecutors. We're going to have 2 new judges. We're going to lose Judge Smeltzer's brain trust of all of these years that he's accumulated as he retires in the summer. And then we're going to, at some point in time, move from virtual back to in-person court sessions and have to decide about them and meetings and all of the above. So I don't know. I mean, I think that Judge Smeltzer made a great suggestion with regard to the new judges to invite them to shadow and to do some training with us over the summer before they actually are seated on the bench in August. But are there other things that you all can think of that would be helpful to us as we make these somewhat large transitions? And let's just take the new judgeship, and or if there's anything lingering on the prosecutorial side, to discuss that. And then let's just have a quick discussion about post-COVID court sessions. So suggestions as to what things that we might want to do. I honestly would not have come up with myself with Judge Smeltzer's suggestions. So many brains make better planning.
Just quickly, Chris, just think how much fun this is going to be. That all you folks, when you're working with 2 new judges come in, you're all going to know more about this than they do. So you get to tell them what to do. Pretty
And
fascinating.
what would be different about that than now? Oh,
Well, that's
wait.
true, but I'm only speaking for myself. I mean, yeah, I get told all the time. I get it, but I do appreciate the guidance that my teammates here give to me. I do appreciate that.
Now it's going to be, if COVID was the defining piece of 2020, all the changes in our system are going to be the defining piece of 2021. Or most likely anyway.
Yeah, there's a steep learning curve. So I think if we can get them more acquainted with the model prior to taking office, because really there's no overlap in the judges. Judge Smeltz will retire one day and then the next judge will come in the next day. So if you do have ideas or thoughts, certainly send them to Derek or myself or Chris. But we'll continue to work on
if you
this.
see materials that would be helpful, I know we can talk about maybe how to use some of those TCP materials and at least get them out to the 3 judicial candidates. I don't know that they're going to necessarily have time to read them or look at them, but at least for us to start to get materials into people's hands in preparation, because it's going to be here very, very soon. Tomorrow. That's how that works. All right, and then I just wanted to plant a seed, and I know that we're bumping up against like 1 minute of time, and so we don't have to have this conversation right now. We can certainly have it again when we meet in a quarter. But one of the things that I would like to think about is, I know that we've been entirely virtual, generally entirely virtual for our participation. I know that for some people that's worked, for other people that hasn't worked, both within the system and as well as the participants. But I'd like to at least plant the seed that we consider whether or not there's going to be any means to continue some form of virtual participation in the future. And just as a brainstorm, like, do we think about giving people three passes a year or 5 passes a year or something that allow them to attend treatment court virtually instead of in person? So if they're sick or they're with a sick child, or they have an employment conflict, or they have transportation conflict, or whatever, that they can come to, they're able to appear and then not miss the court. Because as a general rule, people have been able to appear on a regular basis because they have virtual technology. And I'm just curious as to the groups. That's just my not being a regular participant in court thinking about that. But if there are other thoughts of people of whether or not it might be worth considering something like that going forward.
Yep, we'll table it and put it on the agenda for the next time we meet. But start thinking about different opportunities or changes, and we'll probably know more by then too, as far as when we might be at the end of this.
Okay. All right. So I believe that that's all. So since we have effectively combined 2 oversight groups, we will, or that will be formalized tomorrow, we will then be on a quarterly schedule of meeting. And so we will meet again on May 12th, Wednesday, May 12th at noon. So thank you all for being here. It was a nice group.
Thanks, everybody.
Have a good day.
Bye-bye.